Okay, so one of the most important thing in cardiac pharmacology are antiarrhythmics. Okay, so we'll be talking about antiarrhythmics, and in this whiteboard explanation, I want you to nail down on the facts which are high yield and frequently tested. Antiarrhythmics. Okay, perfect. Now, antiarrhythmics usually we have to study four classes of antiarrhythmics: class 1, 2, 3, 4. And if I talk about arrhythmias are abnormal heart rhythms. Now they can be in terms of rate as well as rhythms. Like, for example, if the heart rate is more than 100, we call that thing as tachyarrhythmias. Okay, and if heart rate is less than 60, we call those things as brady arrhythmias. Now, depending on the rhythms, we have different nomenclature. We have, if the arrhythmia is originating above the atrioventricular junction, we call that as supraventricular arrhythmias, and if it's below that, that's ventricular arrhythmias. Okay, so these are different kinds of arrhythmias and heart rate problems. And in order to convert or control those rhythm problems, we have some drugs, and they are called as antiarrhythmics. Okay, now by any chance we have four classes. Okay, now we follow something called as Vaughan Williams classification. Okay, Vaughan Williams classification. Now, this is the Williams classification what we are following. um by any chance, do you guys know what four classes of antiarrhythmics are currently, what we are going to study? What are the four classes of antiarrhythmics which we are interested in? Just trying to close down the programs. Okay, what are the four classes? Class 1, 2, 3,
1A.
and 4. Okay, what's the mechanism of class 1, 2, 3, 4?
Sodium channel blocker.
Very good.
First,
Huh?
uh, second is beta blocker.
Very good. Third is?
Potassium channel blocker.
Okay.
Fourth
And
is calcium channel blocker.
calcium channel blocker. And just as a bonus, there are like new additional classes as well. But I'm just going to talk about the fifth class now, which contains magnesium and adenosine. Okay. Magnesium and adenosine. But um, you can afford to forget that magnesium and adenosine. That's in the class 5, class 5th antiarrhythmics. So these are the five classes of antiarrhythmics: sodium channel blockers, beta blockers, potassium channel blockers, calcium channel blocker, and the fifth class. Now you can remember this by the mnemonic saved by pharm class. Okay, sodium channel blocker, beta blocker, pharm, that's P, potassium channel blocker, and calcium channel blocker. Okay, now if I just extend this discussion, the class 1 antiarrhythmics are further divided into three classes depending on how much stronger they are blocking the sodium channels. Okay, so class 1A, class 1B, and class 1C. These are also sodium channel blockers. So depending on how strongly they block the sodium channels, you have divided into subclasses. Now, if you look at the affinity to the sodium channels, you have to remember that as C greater than A greater than B. Okay, meaning it doesn't follow ABC, it follows CAB, CAB. You have to remember CAB. So C, class 1C, are the drugs which can bind to the sodium channel with strongest affinity as compared to class B, class A, as compared to class B. So C is having the highest affinity for the sodium channel, A is having moderate affinity for the sodium channel, B is having minimal affinity for the sodium channel. And that will decide what arrhythmias, on what conditions should we give these drugs to the patient. Okay, So class CAB, you have to remember this. That's also frequently tested, the affinity of the sodium channel blockade. Okay. Then we have we'll be talking about the other classes as well. Now, just to recapitulate rapidly, we are going to talk about the pacemaker potential and the ventricular action potential. Okay. Now, the pacemaker potential. Can you rapidly tell me what are the three phases of pacemaker potential? What are the three phases? Okay. I'm just going to delete this. Can I? No. Um, Three phases. What is this? The bottom phase. What is this phase of action potential? This one. Phase.
Phase 4.
Phase 4. Very good. Phase 4. What is this?
Phase 0.
Phase. Huh?
Phase 0.
Very good. Phase 0. And this one? Phase?
Phase 3.
Very good. Phase 3. Phase 4, which is also called as, what kind of channels do we have here? Funny current, right? Funny
Yeah.
current. And in the end part of the phase 4, just little part, if you guys remember, we talked about just the end part of the phase 4 is determined by one type of calcium channel, and which is calcium channel, T type calcium channel. Okay. Now T means transient. Okay. Transient type calcium channel. Phase 0 is mediated by what electrolyte?
Calcium.
Very good. That's, we are talking about pacemaker potential here. Okay. This is not ventricular action potential. So phase 0 is mediated by calcium channel and calcium. So what kind of calcium channel is responsible for the phase 0? L type. Okay. So that's L type, which is also called as a long acting calcium channel. Remember, this is T type, that's transient acting calcium channel. L type is long acting calcium channel, which is responsible for the phase 0. And this is mediated by calcium. This is in contrast to ventricular action potential, which starts with, what is this phase in ventricular action potential? The straight phase. This one.
Phase 0.
0. And this is
Phase 1.
1. And the plateau is 2.
Phase 2.
Very
2.
good. And this
Phase
is 3. And then finally, the phase 4, right? Which is the resting membrane potential. If you note, we don't have phase 1 and 2 in pacemaker potential, but we do have phase 1 and 2 in ventricular action potential, right? And so here we talked about the phase 0 is by the calcium, phase 4 is by the funny current, and the last part of the phase 4 is mediated by T type. I'm telling you because this T type calcium channel, it's mediated by calcium, right? So when we have the beta receptor activation, cyclic AMP, and ultimately calcium would come. So if you give beta blockers, this T-type calcium channel will not be activated, and you have the decrease in slope of the phase 4. That's the class 2 antiarrhythmics. That's why I'm focusing on why these channels are important. Now, this is the T-type calcium channel. That's like the last part of phase 4. Phase 0 is calcium channel, the influx of the calcium channel, and phase 3 is just the efflux of.
potassium.
Very good. So efflux of potassium. That's the phase 3. Okay. Now similarly, the ventricular action potential is, it's pretty straightforward, right? We know this. This is by sodium channel, in contrast to phase 0 in pacemaker potential is mediated by calcium channel. So this is ventricular action potential, and this is pacemaker action potential. So this is by sodium channel. What is mediated by phase 1? Initiation of opening of
Potassium.
potassium. Potassium goes outside. That's why we have a little negative. What happens in phase 2?
Calcium.
So it's potassium is, it's keep it's, potassium is going outside, at the same time calcium is coming inside. So it's both potassium and calcium which is making the plateau. And then finally phase 3 is only
Potassium.
potassium. And then phase 4 is the resting membrane potential, which is mediated by sodium potassium ATPase. Okay, sodium potassium ATPase. Now, if you, so this is sodium, this is potassium. The reason why I'm telling you writing potassium, potassium, potassium in 3 phases here, because in class 3 antiarrhythmics, you'll know that if you are blocking potassium, that will affect phase 1, phase 2, and phase 3. It's pretty simple, right? It's just the action potential which we learned. And if you just apply those concepts here, it's going to give you the mechanism of the mechanism what we are going to learn. Now, after having learned this, let's talk about class 1 antiarrhythmics. Okay, class 1 antiarrhythmics are sodium channel blockers. Okay, so in which phase of ventricular action potential do you think the class 1 antiarrhythmics would work? Which phase of ventricular action potential? 0, 1, 2, 3, and 4. Where would class 1
Zero.
Excellent. So it's the phase 0 of the ventricular action potential where the class 1 antiarrhythmics work. If you block the sodium channel, right? If this is the heart, here is the SA node. Normally, SA node should fire. It should go to the AV node and finally to the uh, bundle of His and the bundle branches, right? So this is how the signal should propagate. Now, once the SA node fire via the pacemaker potential, the surrounding cardiac cells would start to depolarize. And will start to depolarize. It will have sodium influx, sodium influx, sodium influx, sodium influx, sodium influx, sodium influx everywhere via the help of gap junction. That's why it's all synchronized. Once the SA node depolarize, it will send the impulse to the surrounding ventricular, the atrial cardiomyocyte, that it will start rapidly opening up sodium channel and they will start depolarizing, and that depolarizing is spread rapidly to the entire atria with the help of gap junctions, connexins, right? Remember, now if you block those sodium channel, no doubt the SA node is firing, but it will not allow sodium influx in the respective cardiomyocytes, right? It will not allow sodium influx in all other the atrial and the ventricular cardiomyocyte. So what should happen to the slope of phase 0? Where should we should this is the initial slope of the phase 0 of the ventricular action potential? Should it go towards the left or should it go towards right?
Right?
Very good. And so if I say the slope of the phase 0 is going towards right, that means is it rapidly depolarizing or it is taking some time to depolarize?
Taking some time to
Taking
depolarize.
some time to depolarize. Very good. So this is actually on the y-axis. We have the voltage, right? If you look at this graph, the entire graph on the y-axis, you have the voltage in the millivolts, and on the x-axis we have the time, right? On the x-axis we have the time. So if you look at this, in no time initially, if there are no sodium channel blocker, it rapidly depolarizes. But if you give the sodium channel blocker, it is going to shift the slope towards right side. That means it's going to take more time to depolarize. Now this is what we want, that it should take more time. We are blocking the sodium channel, it is taking more time to depolarize. That means if we are giving in arrhythmias is all about automaticity, ectopic foci, and some early and late depolarization. Okay. Arrhythmia is all about automaticity. That means normally SA node should fire, but other parts of the atrias and the ventricles are also firing. It's all about automaticity. The other atrias and ventricles should not act that smart. Okay, if it's the function of atria, function of SA node, it should let that do. But sometimes SA node is like, you know what, I'm not firing. Then the other ventricles and the atria say, okay, we got to do something. So it's the automaticity. And because of that, if there is one foci which is firing, that means there is more sodium depolarization there. So you are blocking the sodium channel. That means we are decreasing the rate of depolarization there. That's what we want, right? That's how the antiarrhythmics are working. So we are working on automaticity. We are working on depolarization, the early and the late depolarization. And then we are working on ectopic foci. Now, this all arrhythmias must have some underlying causes, right? If you are seeing some patient with arrhythmias, he might be having some hypoxia, some coronary artery issues, he might be having some sympathetic overdrive. Okay. Now, most of the antiarrhythmics which you see, which we are trying to focus either on ectopic foci, we are trying to focus on the depolarization, or we are trying to decrease the sympathetic drive with the help of beta blockers. Okay, so that's how the antiarrhythmics are working. So we are decreasing the slope of sodium, okay, mainly in the ventricular action potential. So for now, just trust me and remember, if I talk about class 1 and class 3 antiarrhythmics, you have to think about ventricular action potential. Class 1 and class 3, you have to think about ventricular action potential. That means it is going to alter the slope of the ventricular action potential, this graph. Okay, ventricular action potential. If I talk about class 2 and class 4, where do you think it should work? In which action potential? Class 2 and class 4 should work in pacemaker potential. Okay, so if they talk about all the crazy slopes, please think class 1 and class 3, think about the slopes of the ventricular action potential. Class 2 and class 4, think about the slopes of pacemaker potential. It's not difficult to understand because in class 1 we are blocking sodium. That's why the phase 0 will go to the right side. The slope will go to the right side. In class 3 we are talking about potassium channel blocker. So the phase 3 of the slope will shift to the right side. In class 2 and 3 we are talking about calcium. Okay, and calcium is more on the late part of the phase 4 and the phase 0. That means it's going to affect the phase 4 and the phase 0. Okay, if I talk about class 2 and class 4. Any questions until now? Are you guys clear? Okay,
Yes, sir.
wonderful. So continuing on class 1 antiarrhythmics. So by now you know that they are blocking the sodium channel. And if you are blocking the sodium channel, it is going to decrease the slope of phase 0. It is going to decrease the slope of phase 0. So this is how the new action potential will look. And the remaining part of the curve will depend on the type of class 1. Is it blocking potassium? Yes or no? If it's blocking potassium, then it will also extend the slope of phase 3. If it's not blocking the potassium, it will not extend the slope of phase 3. Okay. Now, if I say I'm blocking sodium channel, what kind of change in EKG would you expect? If this is the P, this is the QRS complex, and this is the T. What change in EKG would you expect? We talked about the ventricular action potential, that is decreasing the slope of phase 0 and phase 3. What happens to EKG if you are getting sodium channel blockers? Please remember, so if you are giving sodium channel blockers, your QRS will widen. This is how the EKG will look. The QRS complex widens with the sodium. And that's what it's intuitive. Because if the action potential goes to the ventricles, ventricles are depolarized with the help of sodium. If you are blocking sodium, the ventricular depolarization rate will be delayed. So widened QRS is a hallmark of sodium channel blockers. Okay. So that's widened QRS, what we see with class 1 antiarrhythmics. Okay. Now, most of the sodium channel blockers are rate dependent. That means if it's tachycardia, if the patient is having tachycardia, you block sodium channel, it will decrease the rate of depolarization and it will help with tachycardia. And that's what we want. Okay. Now, 3 classes of sodium channel blockers. Let's first try to remember the names of 3 classes of sodium channel blockers. So class 1A, 1B, and 1C. Okay, what kind of drugs do you know falls under the class A?
Procainamide.
Very good. Procainamide. What else?
Quinidine.
Very good. What else? One more. One which starts with D, which I used to forget a lot, and USMLE would always test on that. That's disopyramide. Disopyramide. Okay, so we'll remember double quarter pounds. Okay, double quarter pounds. Disopyramide, quinidine, and procainamide are class 1A antiarrhythmics. One special thing about class 1A antiarrhythmics, which is only in class 1A, apart from blocking the sodium, it also blocks potassium channel. Okay, that's why the graph which I draw here is specifically for class 1A. It is blocking sodium, plus it's also blocking potassium. So the slope of phase 0 is also decreasing. The slope of um, phase 3 is also decreasing. Okay, double quarter pounds. How about B? What are the drugs you know? Double quarter pounds. Then
Lidocaine.
lidocaine is a very, very important drug for class 1B. Lidocaine. And we also have one more.
Phenytoin.
Oh, phenytoin. I do remember phenytoin is also um, in class 1B, but we no longer use that as antiarrhythmic. But it does have property of sodium channel blocking. So very good, Tamara. And we also have one more. Lidocaine, phenytoin. What else? There's one more, maxilitine, but let me omit that, maxilitine. I'm not going to write that down. So double quarter pounds, in double quarter pounds, you go to a Subway shop, you give, double quarter pounds, quarters, um, and pounds. You order a bun, add some lettuce. Okay, this is lettuce. And then finally, class 1C. What's that? How many drugs do you know? Class 1C. So you add some lettuce. Okay, let's add also some mayo and write here maxilitine. Maxilitine. So you give double quarter pounds, add some lettuce and mayo, and then what? What do you want? Fries, please. Fries, please. And what is F in the drug? Flickanide. Flickanide. And from P, what do we have? Propafenone. Propafenone. Okay. So these are the class 1 antiarrhythmics. Double quarter pounds, add some lettuce and mayo, and then you always need fries, please. Okay. Now, one thing you already learned, class 1A, apart from blocking sodium, we also block potassium channel. And you also know the affinity of the blocking of the sodium channel. And the affinity of the sodium channel blocking is given by who is the most strongest in blocking sodium channel?
C.
Very good. Followed by?
Class,
A. B.
class,
Very good. CAP. That's the affinity of the sodium channel blockade. Okay. Perfect. Now, continuing on class 1A antiarrhythmics. Okay, we talked about double, quarter, pounds, and once again it's disopyramide, quinidine, and procainamide. Okay, now since it's blocking both sodium and potassium channel blocking properties, it's going to increase the slope of phase 0 as well as phase 3. Okay, so it's going to increase the slope of phase 0 and phase 3. What do you think will happen to the total action potential duration? Total action potential duration in class 1A antiarrhythmics. It will increase the action potential. Yes, so it's increasing the slope here, it's also going increase. So initially its action potential is like this, now its action potential with starting from here it's like this, right? So the action potential duration increase. Now if the action potential duration increase, there's also something called as increase in effective refractory period. I'm taking this very, very slowly because I struggled a lot in this. Effective refractory period. Effective refractory period means no matter what stimuli the cardiomyocytes get, it will not respond to that stimuli. And that's all about arrhythmias. Automaticity, ectopic foci. If it gets irritated, it will start firing. But you increase the effective refractory period, no matter what signals you give, it will not respond to that signal. That's what we want. It will increase the effective refractory period. It will just become resistant to signals. I don't want to respond. Okay, that's one of the main thing we want to have for antiarrhythmics, right? It's going to increase the effective refractory period. Now, but the problem is, apart from blocking the sodium channel, which is going to increase the QRS duration, if it's blocking the potassium channel, what is going to increase in the EKG? If it's blocking the sodium, we know that it widens QRS. If it's blocking potassium, what it will do to the EKG?
QT interval increase.
Very good. QT prolongation. That's one of the side effect of class 1A antiarrhythmics. It increases the QT. It also increases the QRS complex. And once you increase the QT interval, you have increased incidence of, increased risk of what kind of arrhythmias? Okay, big hint.
Ventricle.
Ventricular arrhythmias. What kind?
Tachyarrhythmia.
What kind? Torsades. Torsades. Polymorphic ventricular tachycardia. You remember? Like this. This is torsades. So polymorphic ventricular tachycardia, once you have increased QT interval, you increase the risk of torsades. Polymorphic ventricular tachycardia. I'll be really impressed if somebody says the treatment of torsades if the patient is hemodynamically stable. Treatment, if the patient is hemodynamically stable, is going to be, any guesses? The answer is magnesium sulfate. And if the patient is unstable, the answer is going to be, of course, defibrillation. You shock the patient. Okay. Now, the thing I want you to know why magnesium is very important in arrhythmias. We always want that you should maintain potassium levels of more than 4, magnesium levels of more than 2. This is a bottom line of any arrhythmias. Why do we want that? Because if you have low magnesium, remember the sodium channels are surrounded by magnesium. And what kind of ion is magnesium? Positive, 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 positive. Okay, so if you have magnesium, it's going to surround the sodium channel. Okay, And if it's surrounding the sodium channel, uh, if it's surrounding the sodium channel, the sodium is also positive charge. If it's a lot of magnesium, it will try to repel the positive sodium. If it's less sodium, it will not repel, and more sodium will go inside into the cell, and which may cause the arrhythmias. So hypomagnesemia is very much associated with arrhythmias. So you give more magnesium, you give 4 grams of magnesium if the patient has torsades, that will surround the sodium channel. It will stabilize the cardiac membrane and will decrease the incidence and risk of arrhythmias. Any questions? One of the problem with magnesium is, since it's surrounding the sodium channels, sometimes also surround the calcium channels in the intestine, it will not allow the further influx of the action potential in the intestine as well. So problem is with magnesium, it can cause constipation. Okay, so it just surrounds the channel. It will not allow the positive ion to come because it will repel. Okay, wonderful. So one thing you already know, it's going to increase the QT, so increase risk of arrhythmias. Now, uses, we can use it in ventricular tachycardia, supraventricular tachycardia. um, Adverse effect. Adverse effect. What's the adverse effect of disopyramide? Just remember, it has some anticholinergic effect. Anticholinergic. What's the adverse effect of quinidine? This is never miss. You should know the adverse effect of quinidine. Quinidine belongs to a class which is similar to aspirin. Oh, similar to uh, chloroquine, chloroquine and primaquine. So, what kind of adverse effect would you expect with quinidine?
Phototoxicity.
Autotoxicity, and there's a word starting from C which is called as,
Synchronism.
very good, synchronism. I have kept my iPad beside me so that I can look up the spellings. Synchronisms. Okay. And the classic features of synchronisms are headache, you get tinnitus, ringing in ears is very, very important sign. I said that in aspirin, because in ringing of ear is also a sign of aspirin toxicity. Okay. So please remember what quinidine, synchronism, and one thing you want to remember is tinnitus, ringing in ears. What about procainamide? One side effect of procainamide, which I'll be really impressed. What is that? Do you remember ship drugs? Sulfur, hydralazine, isoniazid, and procainamide. Sulfur drugs, hydralazine, isoniazid.
Drugs induce lupus.
Very good. Procainamide. This is procainamide, class 1A antiarrhythmics, drug induced lupus. Okay. What kind of antibodies will you see in the blood?
Antihistone.
Very good. Drug induced lupus, and you get antihistone antibody. Okay. Antihistone antibodies. Procainamide, sulfur drugs, hydralazine. I've seen a patient with drug induced lupus who was on hydralazine. Why do we give hydralazine? Hydralazine is arteriodilator, right? It will reduce the afterload. And combination of hydralazine and nitrates may decrease the mortality. So many patients will be on hydralazine and isosorbide dinitrate, nitrates. So hydralazine nitrates combination may decrease mortality. So I have seen a so drug-induced lupus patient came with diffuse alveolar hemorrhage. Okay, so it's a thing. Okay, you will see that in the wards. Okay, I think that's about class 1A antiarrhythmics. So bottom line is, class 1A is a moderate sodium channel blocker which is going to increase your QRS, increase your QT, increase your action potential, increase your effective refractory period. Okay. And that's the intermediate phase 0 blocking. Perfect. Now let's go to class 1B. Class 1B in our chart is C greater than A greater than B. Class 1B is the least affinity for the sodium. And sometimes it's good for us. And so in class 1B, we have lettuce and mayo, right? Lettuce, that's lidocaine. We use that as a local anesthetic, right? Lidocaine and mexilatine. Mexilatine, lettuce and mayo. Lidocaine is a lignocaine, lidocaine. These are all local anesthetic which we use, and the mechanism is also important for local anesthetics. You have to remember it's blocking the sodium channel. Even for the local anesthesia, if you block the sodium channel, it will decrease the nerve conduction velocity. That's why you will not feel anything. Okay, but you have to remember. I don't know in which chapter I talked about this. The action of the local anesthetic will depend on the local pH. If the pH is very acidotic, your local anesthetic won't work. Like for example, in abscess, your local anesthetic will not work, so you might have to do something more. Okay, so lidocaine and mexilatine. If I just tell you, remember only one thing about class 1B is these are very very good drug, especially lidocaine, very good drug if somebody has MI, and after MI they get ventricular tachycardia or ventricular fibrillation, okay, or ventricular um, uh, post mi ventricular arrhythmias are very 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 responsive to lidocaine. Okay, so ventricular fibrillation is a kind of cardiac arrest. Okay, so you just don't wait for lidocaine to kick in. Ventricular tachycardia, the patient might, if the patient has pulse, you may just give lidocaine. Okay, in ventricular tachycardia, ventricular fibrillation, if the patient does not have pulse, you of course start CPR. Okay, so don't fall into the trap. um, but that's more advanced. I just want you to remember ventricular arrhythmias post mi. If somebody got myocardial infarction, after that he has some arrhythmias, please give IV lidocaine. It's going to block the sodium. It is going to decrease the tachycardia. It is going to decrease the risk of further ventricular arrhythmias. Now, since it's blocking the sodium channel, okay, since it's blocking the sodium channel, it's going to definitely decrease the slope of phase 0. But do you think it has potassium channel blocking property, class 1B? The answer is no. So do you think it's also going to decrease the slope of phase 3?
No.
No. So it's not going to decrease the slope of phase 3. Rather than that, it's um, the action potential duration will decrease. So decrease in action potential duration. Okay. Decrease in action potential duration. What will happen to the QRS complex in EKG? Do you think that will change?
It's normal.
Yes, it is going to change because it's a sodium channel blocker. So QRS will ideally should increase. Okay, if because it's a
What
sodium
did you
channel
say?
blocking. Huh?
I thought it's QT interval. Sorry.
Oh yeah. So QT does not change. QRS theoretically will increase, but sometimes, most of the time, it remains normal. Okay, QRS may remain normal, but let's say for our purposes, because it's a sodium channel blocker, we'll keep it that the QRS should increase. Okay. All right. QT interval will remain same. QT should be normal. All right. And the affinity, do you know that's the weakest affinity? And that's why, because it's the weakest affinity, it is more preferable in myocardial infarction. If you give other drugs, like for example, class C, which is fries, please, flecainide, and propafenone, if you give those drugs, if the patient has post-MI arrhythmias, they are more pro-arrhythmogenic. If you give them, that increases further risk of arrhythmia and patient will die. So it's never a good idea to give class C because it has the strongest affinity for the sodium channel. It will keep on binding and it will further increase the risk of arrhythmias. Okay, so you always want to give weakest sodium channel blocking if the patient has MI and after that they get arrhythmias. Okay, perfect. You might also want you to, want to understand at this point, since lidocaine is a local anesthetic, when you give some local anesthesia, you always want to aspirate and see you are not in veins or the arteries. If you are in veins and arteries, if you push the lidocaine so much in the veins and artery, you might get cardiac arrest. Okay, so be be careful. You want to, like, if you're giving local anesthesia, be careful, make sure you are not in veins and the arteries. Okay, all right. Now, since it's a weak sodium channel blocker, it can preferentially bind with the ischemic tissue. That's why it's a very good drug for post MI. What else? What are some adverse effect? Um, you're blocking sodium channel. So what do you think it can do to the central nervous system? Adverse effect. If you're blocking sodium channel, what can you do to the CNS?
Depress.
CNS depression, right? Um, so one of the very easy thing is you might get depression with, but that's what something which we are not interested in acute setting, right? Um, if you block the sodium channel, it may alter the electrical activity of the brain and you might get seizures. That's one of the very important side effect we want to know. So that's your brain, and that's expected. You block the sodium, you may alter the electrical activity of the brain. And the next one is heart. Since you are blocking the sodium itself, it can cause bradyarrhythmias and sometimes cardiac arrest. Okay, so it's going to decrease uh, the function of the heart. Okay, so it may sometimes cause cardiac depression. So those are the side effects of class 1b. Now, you also have some other friend. If you don't know what to use, you may always choose amiodarone. But if you know the patient had coronary artery disease, came with MI, you put some stents, and after that the patient has having arrhythmias, you go with lidocaine. Otherwise, you may choose uh, amiodarone. Any questions? Okay. Phenytoin is also in class B, as Tamara said. Okay. Let's go to class 1C. Class 1C. And we have what two drugs in class 1C? Price.
Lecainide,
Very good.
propafenone,
Perfect. Propafenone. You nailed it. Propafenone. I still have to verify the spelling. Oh, I'm surprised. Propafenone. Okay, it's the correct spelling. So flecainide and propafenone are class 1C. And that's the danger list. CAD. That's the most strongest affinity for the sodium channel. Okay, strongest affinity for the sodium channel. If you look at the action potential graph, this is the normal action potential. It is going to decrease the slope of the phase 0, but this slope is kind of remaining same. Okay, it just decreases the slope of phase 0. So theoretically, I want you to remember, it may decrease the action potential duration, but it may also keep it the same. Okay, theoretically you are seeing it's decreasing the slope, right? So it should decrease the duration of action potential. Okay, it's decreasing the action potential duration if the slope is decreased. The other thing is strongest sodium, so strongest sodium channel. So it will not dissociate fast. Not, you have to remember this, not dissociate fast, meaning it will keep on attached and bound to your sodium channel. If it's bound to your sodium channel, you have a problem. That can increase the risk of arrhythmias. So that's why these drugs are pro-arrhythmogenic. Arrhythmogenic. That's why before prescribing flecainide, propafenone, you have to rule out coronary artery disease. You have to rule out any congenital heart disease. You have to rule out any structural heart disease. Rule out everything. If there is anything, don't give these drugs. If you give, they are prorhythmogenic, and that can increase the mortality. So you cannot give flecainide and propafenone if somebody is having left ventricular hypertrophy, interventricular septum hypertrophy, right ventricular hypertrophy, left ventricular failure, left ventricular dilatation. You cannot give this, okay? If just patient has atrial fibrillation, otherwise everything is normal, then you can give this, okay, to maintain the atrial fibrillation in sinus rhythm. So structural heart disease is a no, no, you cannot give this. They are contraindicated, okay? So what else? So I already told about one thing. You may use that in atrial fibrillation to maintain sinus rhythm, not convert to sinus rhythm. The patient should be already in sinus rhythm. Then you give this drug which can maintain sinus rhythm. Okay. If the patient is actively in atrial fibrillation, if you give this drug, it will have no effect. If the patient is in actively atrial fibrillation, you give amiodarone, patient may convert into sinus rhythm. That's called as pharmacologic cardioversion. Flecainide and propafenone can maintain but cannot convert into sinus rhythm. Okay. So what they usually do, if somebody is having atrial fibrillation, you want to shock the patient, elective cardioversion. Before shocking the patient, you load the patient with flecainide and propafenone. So after cardioversion, patient will maintain the sinus rhythm. Okay, so that's how these drugs are used. Now, since it's strongest binding to the sodium channel, USMLE would love to ask rate dependence. Rate dependence. Now, does anybody know what is rate dependence? What should happen to the heart rate QRS complex if the patient is running? What should happen to the QRS complex with the heart rate in class 1C, because of the given fact that they bind to the sodium channel very strongly. Rate dependence, that means, let's say normally I'm exercising. This is your normal QRS. What do you think should happen to your QRS complex when you're exercising? It should get widened or narrow?
Narrow.
Narrow. Thank God. Very good. Should get narrow. Okay. Your QRS complex should ideally get narrowed when you're exercising. But if the patient is on flecainide and propafenone, as you start exercising, or if the patient is doing stress test, this is before exercise, let's say, you'll have some amount of QRS prolongation because it's a sodium blocker, right? But I'm just whatever, exaggerating the evidence, exaggerating. So with exercise, you widen your QRS. This is called as rate dependence. With high heart rate, instead of narrowing the QRS, your QRS prolongs, and this is very, 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 very important. Okay. Rate dependence is showed by which of the following classes of drugs? Class 1C. Okay. Flecainide and propafenone. Very important. Okay. And you know why? Why? Because it is strongest. Okay.
Sir, I have a question.
Sure.
So how do you define rate dependence?
Rate dependence means the action of the drug depends on the heart rate. So if you have a slow heart rate, flecainide and propafenone will get enough time to dissociate because the heart rate is slow. But if heart rate is fast, 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 it will not get time to dissociate it. So it will keep on hanging with the sodium channel. So when it keeps on hanging with the sodium channel, the QRS will keep on widening. Right? So if rate dependence means if the rate is fast, it will not get enough time to dissociate and the QRS will widen.
Oh, okay, sir.
Very good.
Sir, I also have a question, sir, about how do you describe the slope if the slope is going to the right? Is it increase or decrease?
Oh, so it's decrease rather than it is decreasing slope. What did I tell?
Uh,
Or did I tell increase?
no, I just
Okay.
a little bit confused with the terms.
So no. You are right. It decreases the slope. So it's that's in makes the slope towards right. So look at this. If you are going with your bicycle here, whoo, you will get more down, right? As compared to this. So this is a kind of a decreased slope, and this is further decreased slope. So decrease in slope.
Okay. Sir, I actually want to ask why, if you see in the Google,
Uh-huh.
uh, the graph for antiarrhythmic drugs,
Uh-huh.
why the slope of the class 1C drugs is more to the right?
So I didn't get that. What?
Uh, is the affinity affect the s- the steepness of the slope?
Yes.
Oh, okay. So that's why class 1C has the slope that is more to the right, right?
Yes, you are right. You are right. That's
Okay.
why the class one, because it's strongest, it will further decrease the slope. It will shift more towards right.
Okay. Thank you, sir.
Very good. Very good. Any more questions?
No.
Okay. Now, have you guys must be knowing Wolf Parkinson White syndrome, right? In Wolf Parkinson White syndrome, the problem is because you have accessory bundle, right? And that's called as bundle of Kent, right? So normally when the signal should pass through SN node to AV node and finally to bundle of A's to bundle branches, sometimes mm, through bundle of Kent, it does this. And what is this phenomena called as? What is this called as? You go round and round and round. What's this
Re-entry.
very good re-entrant? Re-entry phenomena, okay, in Wolf Parkinson White syndrome. So in Wolf Parkinson White syndrome, if you give AV nodal blockers like class 2 and class 4, beta blockers or calcium channel blockers, you're blocking this. Is it going more good or more harm to the patient? If you block AV,
Good.
it's more harm. When
Oh,
the SA nodes fires, now you cannot go through AV nodes, it will go through the bundle of Kent. Can further propagate. Now we have two kinds of re-entrant circuit, right? So you can go counterclockwise re-entry and clockwise re-entrant. Okay, they are like anterograde, retrograde. Okay, the clockwise and the counterclockwise re-entrant circuits. That's all about electrophysiology. Um, so if you give AV node, they are actually contraindicated in Wolf Parkinson White syndrome. So you cannot give beta blocker, you cannot give calcium channel blocker, you cannot give anything which can depress your AV node. So the drug of choice for Wolf Parkinson White syndrome induced supraventricular tachycardia. This is called a supraventricular tachycardia, okay? Is procainamide. Okay, very important. Procainamide is drug of choice for Wolf Parkinson White syndrome induced supraventricular tachycardia. Okay, wonderful. Okay, that brings us to um, this beautiful graph. If you look at the affinity, if I write on the x-axis number of sodium channel blocked, and on the y-axis if I write time, and I'm giving you three options. This is graph 1, graph 2, and this is graph 3, and you have to tell me I am writing this as QRS, which is class 1A, which is class 1B, and which is class 1C. Match the following.
I'm thinking Q is 1C
Very good.
because it has strong affinity.
Very good. And with the time, it's blocking more sodium channel, right? More
Yes.
affinity. Then this should be
A.
very good. And finally,
Mm.
perfect. CAP. CAP. This is the affinity for the sodium channel. Perfect. And if I tell you which drugs would you choose for post-MI arrhythmias, what will be your answer?
Class B.
Wonderful. That should be the class 1B, and that's lidocaine. Okay. Wonderful. Okay. That brings us to class 2 antiarrhythmics, which are pretty straightforward. You guys already know this. Okay. Class B. Sorry, class 2. Class 2 antiarrhythmics, they are called as beta blockers. Okay, who can give me quick and dirty mnemonic which says who are selective beta blockers and who are non-selective beta blockers? I always forget this mnemonic. It's A through what letter are selective and
To
from
N. A to N is selective and M to Z is non-selective.
M to Z is non-selective.
Yes.
Metoprolol is non-selective.
Hmm?
Huh?
Right.
Is it A through M?
Maybe. Sure.
Oh, M comes first, then N, right? L M N. Oh, yeah. A through
Yeah.
M.
Yeah. A to M.
Okay. A through M and N to Z. So these are selective. Atenolol, metoprolol, selective. Then lemon or P, propranolol, that's non-selective. So these are non-selective. This is like quick and dirty way of remembering selective versus non-selective beta blockers. Okay. So um, can you tell me one drug which is both alpha and beta blockers? Which can be very useful for decreasing blood pressures as well as decrease the heart rate.
Lebetalol.
Very good. Labetalol and the name itself has labetalol alpha and beta. Okay, it has both alpha and beta properties. And then carvedilol. These are all lol drugs. Okay, propranolol, labetalol, carvedilol, lol. Okay, all lol drugs. They are beta blockers. Okay, now if you're blocking beta receptors, the heart has beta 1 receptor, right? So if you're blocking beta receptor, which is a GS type of beta receptor, beta 1, G protein coupled receptor, when the epinephrine norepinephrine would bind, it will ultimately, with the help of GS protein, it will activate adenylyl cyclase, which will convert ATP into cyclic AMP. Cyclic AMP will activate protein kinase A, and protein kinase A will phosphorylate calcium channel so that the calcium would come inside. This is the whole story, right? And once the calcium comes inside, you have calcium induced calcium release from the sarcoplasmic reticulum, and then calcium would bind with troponin C, and then you have actin myosin contraction. Okay, that's how the entire contraction happens. And if you look at the pacemaker potential, these are the funny current who, funny current who, funny current who. So this funny current, and the last part of the funny current is the T type calcium channel. This is where mostly the beta blockers are working. Okay. So this is happening in SA node. This is happening in AV node. So when I talked about initially, you have to think about class 1 and 3 antiarrhythmics with ventricular action potential. You have to think about class 2 and 4 antiarrhythmics with pacemaker potential. And in class 2, the beta blockers, it's mainly working on the last part of the phase 4 of the pacemaker potential. If it's not allowing calcium influx, what should happen to the slope of phase 4? Where should it go?
To the right,
To the
decrease.
right. Very good. It should
More
decrease the
flat.
slope. Huh? Very good. Yes. It should be more flat. It should be to the right. It should be decreased. Okay. Now, this is more flat. It's the last part of the T type. So it's more flat. What, in other words, you can say it is prolonging phase 4. And phase 4 is also called as what phase? Is it depolarization, repolarization, or what is the phase 4 called
Depolarization.
as? Huh?
Depolarization.
It is depolarization, that's for sure, because it's going towards positive side. But do you think the heart is contracting when this depolarization is happening in the SA node? It is still not firing. The heart starts to contract when the SA node fires here. Okay. So heart is still relaxing. So should I call it systolic depolarization or diastolic depolarization? Diastolic, right? Because heart is still relaxing in phase 4. It's the phase 0 where the ventricles and the atria would start to contract. So phase 0 is diastolic depolarization. So this is the $10 word, I would say $1,000 word. Prolongs diastolic depolarization. When you give beta blocker, which of the following action is done by beta blocker? It prolongs diastolic depolarization. Okay. Why? Because it blocks the last part of the phase 4, which is done by the T-type calcium channel. Okay. And if I say it prolongs diastolic depolarization, it will take a long time to reach the threshold, and then now it is going to fire. Okay. Then again, a very long time to reach the threshold. Now it will fire. What will happen to the heart rate? Should decrease, right? Yes. Look at this. It's taking long time, then it will fire. Long time and it will fire. So it's working in SA node and AV node perfectly. It's decreasing the heart rate because it's prolonging diastolic depolarization. It decreases the heart rate, which decreases the um, cardiac oxygen demand, and that's why metoprolol are very good in decreasing cardiac oxygen demand. When you decrease the heart rate, what should happen to the diastole? Relaxation. Increase or decrease?
Increase.
Increase in diastolic period. So more blood is filled in the left ventricle. So there'll be more end diastolic volume, right? So it will be filled up more. It will have enough of blood to fill, and then it can do the cardiac output. Um, so that's also a question. It can increase cyclic AMP. But remember, cardiac output is what? Cardiac output is stroke volume times heart rate. You are decreasing heart rate much. That's why the cardiac output may decrease when you give beta blockers. Okay. Mm, what else? Utilities, beta blockers. Where do you think should we give beta blockers to the patient? Uses of beta blockers. Very important. Where should you give? Tell me what's most important.
SVT.
Supraventricular tachycardia. Very good. We may use beta blockers in supraventricular tachycardia for rate control or rhythm control.
Rate control.
Very good. You cannot convert supraventricular tachycardia, atrial fibrillation. Atrial flutter are types of supraventricular tachycardia. You cannot convert back into sinus rhythm. It will just control the ventricular rate. Meaning, if your atria is fibrillating, sometimes it may push some aberrant signals to the ventricles, and your ventricles may prematurely fire. So it's not going to convert it into sinus rhythm, but it's going to do the rate control. Very good. What else?
Atrial fibrillation and also atrial flutter.
Very good. So supraventricular tachycardia has atrial fibrillation, atrial flutter. What else? Where can we use beta blockers? Are they first line for hypertension? What do you think?
The first line for hypertension is hydra. I forget. Thiazide, is it?
Okay, diuretics. That's a very broad class which you can use in hypertension. What else? Calcium channel blockers, ACE
Mhm.
inhibitors, and ARBs. These are
Yes.
the first three lines in hypertension. Do we use beta blockers as a drug of choice in hypertension? No, unless the patient has comorbidities like myocardial infarction. Myocardial infarction, coronary artery disease, myocardial infarction after MI, we want to give beta blockers because they improve mortality. We want to give the patient in compensated CHF, okay, or decompensated CHF, but don't give or start beta blockers when the patient is acutely having heart failure, okay? You can continue if the patient is already on, but don't start if the patient already has CHF. You can choose beta blockers like propranolol if the patient has hypertension plus hyperthyroidism, right? Hyperthyroidism and hypertension, you can use propranolol. And USMLE might want you to know this propranolol. Essential tremors. Beta blockers will help, especially propranolol, essential tremors. You want to give beta blockers, especially labetalol, if the patient is coming to you with aortic dissection. They are first drug of choice. Beta blockers like timolol can be used in glaucoma, topical. Okay. Uh, what else? I think that's pretty comprehensive. Adverse effect. Adverse effect of beta blockers. Five big thing I just want you to remember. Beta blockers should be used cautiously in patients with
Asthma.
asthma, because if you block beta 2, it can cause bronchoconstriction. What else? Di-
Diabetes.
Diabetes mellitus. Why?
Don't know, sir.
If you give beta blockers, beta receptor mediated sympathy, when you have hypoglycemia, you have tremors, sweatings. But if you block beta, you won't have tachycardia, you won't have tremors, you won't have sweating. So it decreases the sympathetic drive. So patient will not know if the patient has hypoglycemia. So you should be using cautiously if the patient has diabetes mellitus. But this is non-selective beta blockers, okay? You can definitely use selective beta blockers if the patient has MI because of the mortality benefit, okay? What else? Severe depression. Okay. What else? Because you are blocking beta, sympathetic drive in the brain may trigger severe depression. Okay. But if the patient is already having severe depression, you try to avoid. But again, risk and benefit. Peripheral arterial disease. I would rather say Raynaud's phenomena. Do you know why should we avoid beta blockers in Raynaud's? Because we have beta 2 mediated vasodilation. If you block that, there'll be unopposed alpha action. It will further cause vasoconstriction. So it may worsen vasoconstriction in patients with Raynaud's. Final one. What is another last contraindication? Asthma, depression, Raynaud's, diabetes. I also forgot. Asthma. Oh, I remember now. Severe heart block. Okay, you want to avoid beta blockers. That's but obvious. Another miscellaneous thing you want to know, in which intoxication you want to avoid beta blockers to be given at first. You should give alpha blockers first, then you should give beta blockers. Which is that intoxication or which condition? Cocaine intoxication and pheochromocytoma. Cocaine intoxication and pheochromocytoma. Please give alpha blockers first and then give beta blockers. If you give beta blockers first, same story. You blocking beta, unopposed alpha action, and severe hypertensive crisis. Patient may have stroke, aortic dissection, and whatnot. So give alpha, then give beta. Which alpha do you think it's best for cocaine and pheochromocytoma? Which alpha blocker you wanna give? Phentolamine. Phentolamine. Okay. Is it reversible or irreversible? That's irreversible. What is reversible alpha blocker then? Phenoxybenzamine. Ah, did I mistake? Ah, phenoxy. Phenoxy. Phenoxybenzamine is reversible or phentolamine is reversible? Oh,
Phentolamine is reversible.
oh, then we have to give phenoxybenzamine. Okay. Oh, thanks. Ooh, phenoxybenzamine. Oh, I remember now. Longer one is irreversible. Okay, longer spelling. Phenoxybenzamine. Okay, so longer spelling that's irreversible. Phentolamine is reversible. Thank you. So we want to give alpha blockers first in cocaine or pheochromocytoma, then you want to give beta blockers. Okay. Any questions? Very good. Then let's go to class 3 antiarrhythmics. Class 3 antiarrhythmics. Can you tell me some of the drugs in class 3 antiarrhythmics? Famous AIDS pneumonia.
Amiodarone.
Huh?
Amiodarone.
Amiodarone. Then
Sotalol.
very good. Then these are the difficult. Ibutilide. And I'll have to look at this spelling. Dofetilide. Oh, that's easy. Dofetilide. Ibutilide and dofetilide are the class 3. Okay. Everybody knows amiodarone and sotalol. Now they'll ask you about ibutilide and dofetilide. Okay. AIDS, amiodarone. You also have dronedarone. Okay. That's just the sister of amiodarone. Dronedarone. Okay. Amiodarone, dronedarone, ibutilide, dofetilide, and sotalol. These are class 3 antiarrhythmics. What's the mechanism? Potassium. But amiodarone is a wonder arrhythmic drug. It blocks sodium, potassium, calcium, almost everything. So it works almost every time. If you don't know what kind of arrhythmia is the patient having, give amiodarone. That's your savior. If you don't know what's happening, give amiodarone. If you know what's happening, then you're a cardiologist. But if you don't know what's happening, give amiodarone. Sometimes you shock the patient, that might change the rhythm which you know, then give amiodarone. So don't do that. Whatever, amiodarone is your lifesaver. Okay, it's the drug of choice for any arrhythmias which you don't know. Works pretty well because it's blocking everything. Okay, people will be also on long term amiodarone, especially if the patient has atrial fibrillation and want to maintain sinus rhythm. Okay, so mechanism, mostly it's potassium channel blocking. Okay, so if it's blocking potassium, as you expect in the EKG, what will happen to the EKG? QT prolongation, right? And QT prolongation will put you at the risk of torsades. But obvious. Um, One thing about sotalol, apart from potassium channel blocking, it also has some beta blocking property. Okay, lol. Okay, um, so all prolongs QT, and what will happen to the action potential curve? What phase of the action potential will decrease the slope? What phase of action potential if it's beta blocking? Oh, sorry, class 3, phase 3,
Phase
right?
3.
Perfect. So phase 3 will prolong. um, that means you are indirectly uh, increasing the duration of repolarization. And remember, this is IK current, potassium. Okay, so you're prolonging the repolarization, increasing the QT, increases the risk of torsades. Okay, prolonging repolarization, that will also increase the effective refractory period, and hence it is helping in arrhythmias. Okay, so increasing action potential duration, broad obvious, increasing QT, and increasing effective refractory period. Okay, so that's the mechanism. And then we are coming towards the uses. It helps to maintain the sinus rhythm. So atrial fibrillation, people will be in long term amiodarone, cordarone, if they have tendency of getting arrhythmias. Okay, atrial fibrillation can be used in supraventricular tachycardia, ventricular tachycardia. Okay, amiodarone can be given if the patient is having ventricular tachycardia and is having pulse. Okay, ventricular tachycardia and is having pulse. What will you do if the patient has ventricular tachycardia and is not having pulse? Oh, 30 seconds already passed. Patient will die. I mean, is already dying. What do you want to do? Ventricular.
Is it useless?
Huh?
So we need to RGP. Sorry, CPR.
CPR. Okay, you start with CPR, and ultimately you want to do what? You want to continue chest compression, you want to give epinephrine, you want to defibrillate. Defibrillate. Okay, ventricular
Okay.
tachycardia or ventricular fibrillation, defibrillation. Pulseless electrical activity or asystole, you continue CPR and then give epinephrine. Okay. Okay. So that those are the uses. Adverse effect are very important. Adverse effect. What are the adverse effect of, oh my god, of amiodarone? What will you say? Adverse effect of amiodarone? or the general class 3 first amiodarone. Amiodarone messes up with your thyroid function. So what is the side effect you can get? Hyper,
Hyper.
or you can get both hyper or hypothyroidism. So baseline, what should you have before beginning the starting patient on amiodarone?
Thyroid function test.
Thyroid function test. What else it can do?
Pulmonary fibrosis.
Very good. So baseline,
Spirometry.
pulmonary function test. Very good. What else it can do? Liver toxicities. So baseline, liver function test. Right. What else can it do? Amiodarone is an iodine compound, so it can do sometimes uh, skin bluish discoloration, blue discoloration of skin, blue discoloration of cornea. Okay. I don't know. Cornea is transparent, right? Iris or whatever. So bluish discoloration of the cornea and skin. What else? Hypothyroidism, hypertoxicity, hyper pulmonary fibrosis, and skin discoloration. And of course, it can cause bradycardia because you're blocking the potassium. Um, if the patient has pulmonary fibrosis, you of course have to stop amiodarone and you start the patient on steroids. That's one important clue. But these are all very high yield. Okay, please remember this. Um, One thing about class 3 is all the drugs can increase the risk of torsades, except what is that? Amiodarone. Amiodarone is a king, right? So all the drugs can increase the risk of QT prolongation, induced torsades, except amiodarone. So it's a very good drug with a lot of side effects. Okay. This class 3 drugs are also interesting about we talked about use dependence. In what group of antiarrhythmics? Use dependence. Class 1C, right? Flecainide and propofenone. More exercise, more widening of the QRS. Class 3 drugs are known for causing reverse use dependence. What do you mean by reverse use dependence? More heart rate, less QT prolongation. Less heart rate, more QT prolongation. Okay? So if you increase the heart rate, there'll be less QT prolongation. This is called as reverse use dependence. We saw use dependence in class 1C antiarrhythmics. Okay? So if you give beta blocker, what should happen to the AV conduction velocity? Sotalol, apart from potassium, it also blocks beta. What should happen to the AV conduction velocity? Increase or decrease? Decrease, right? That's your question. Okay. Class 4. Can you name some class 4 antiarrhythmics starting from B and D? I know you guys are tired. This is the last class. Come on.
Varapamil.
Verapamil and diltiazem. Okay. So they mainly act on AV node and SA node. Remember in class 3, It's about the ventricular myocardium. I didn't talk about pacemaker potential. And in class 4, again, I'm talking about SA node and AV node. Now, class 4, they are calcium channel blockers. So again, we are coming to our same old philosophy. If this is your pacemaker potential, you will have this part which has T type calcium channel and this part which has L type calcium channel. So you are prolonging both phase 4 and phase 0. Okay. So prolonging both phase 4 and phase 0. So decrease in slope of phase 0 and phase 4. That's the classic thing about calcium channel blockers. Okay. So it prolongs the diastolic depolarization. It also prolongs the depolarization, the upstroke. Okay. So it has negative chronotropy effect. That's the thing about calcium channel blockers, right? Now, verapamil and diltiazem are predominantly working on the AV node. We also have other calcium channel blocker like nifedipine, but nifedipine mainly works on the calcium channel of the arterioles, okay, of the blood vessels. Verapamil and diltiazem will mainly work on the AV node, especially diltiazem. Diltiazem we want to give if the patient has atrial fibrillation with rapid ventricular rate. This is the most common thing which you'll see in hospital. The patient is coming with atrial fibrillation with rapid ventricular rate. You start them all diltiazem drip or diltiazem Q4 Q6 hourly, 4 times daily. Okay, and then you later on titrate. So diltiazem is a good drug for AFib with RVR. Okay, so these are negative chronotropic drugs. But the problem is we are blocking calcium channel. So calcium is also responsible for GI, so it can cause constipation. Okay. Um, and of course, it blocks the AV node. I think that's your calcium channel. And lastly, about adenosine, which is class 5 antiarrhythmics. One thing you want to know about adenosine, which can be used in acute paroxysmal supraventricular tachycardia. If your vagal maneuver has failed, you can give adenosine 6 milligram IV rapidly, followed by normal saline push, because it has to reach heart very rapidly in 10 seconds. So one important thing you want to know, it's GI coupled. So finally, that will increase the potassium efflux in your heart. Okay, if the potassium efflux is increased, your heart is going to get hyperpolarized. If your heart is getting hyperpolarized, that means it has more negative potential, and it will decrease the arrhythmia. Okay, one side. So you know the mechanism: potassium efflux, hyperpolarization. That's very important. And once you give adenosine, if the patient is having supraventricular tachycardia, I'm just mimicking this, as this is not SVT. Okay, but once you give SVT, adenosine, you'll have flat line, and then the patient will again have sinus rhythm. So this flat line is scary. One other side effect, with adenosine, patient may have bronchospasm, like feeling chest heaviness, chest pressure, chest pain. They'll feel I am dead. The sense of impending doom. They'll feel like, oh my god, I am just about to die, and their hearts will start pumping again. Okay. So bronchospasm, chest pain, are like the side effect of adenosine. Okay. So that's your adenosine. Uh, Effects are blunted by theophylline and caffeine. So they kind of work as antidote. If it's a lot of adenosine, you may give theophylline or caffeine as the antidote. Okay. And magnesium, if the patient is hemodynamically stable, um, in torsades, you can give magnesium in hemodynamically stable torsades, but if the patient is unstable, you have to shock defibrillation. Okay. All right. I think that's um, your antiarrhythmics. Any questions?
Sir, I have a question, sir.
Sure.
You mentioned previously about RVR
Uh-huh.
for as the clinical use in the class 4. What is
Yep.
RVR?
So very good question. So RVR is rapid ventricular rate. So atrial
Oh,
fibrillation with rapid ventricular rate, meaning when your heart rate is more than 120. So normally you can have atrial fibrillation. You may have irregular rhythm, but if heart rate is 70, we just call that atrial fibrillation. But if patient has atrial fibrillation with heart rate more than 120, that's called as atrial fibrillation with rapid ventricular response or rapid ventricular rate. You wanna start the patient on diltiazem, okay, or metoprolol. Both works in AFib with RVR.
I see, sir.
Very
And then
good.
I'd like to ask, is it correct if beta blocker will decrease AV conduction velocity?
Yes, that's correct as well.
Okay.
Beta blocker should decrease the AV conduction velocity because it's working with the phase 4.
Oh, okay.
So phase 4 is both in SA node and AV node.
Okay, sir.
Excellent.
And then one more question, sir.
Sure.
Uh,
Keep asking.
for class 1C, class
Mm-hmm.
1C, you mentioned previously about use dependence.
Mm-hmm.
Is it the same like rate dependence?
Is it same like what? Rate dependence?
Yeah.
Yes. So use dependence and rate dependence are same. So with low heart rate, low QRS. High heart rate, high QRS. I mean wide QRS.
Oh, I see.
And this was reverse, which we saw in class
Is
3.
it class 3?
Yes, that's reverse
Oh,
use
okay.
dependence. More heart rate, less QT. Less heart rate, more QT. Very good.
Okay. Thank you, sir.
You're welcome. Any more questions? Okay. That concludes our antiarrhythmics then. Great job. Great job. Okay.